Hello, I'm Marcia Day Childress from the Center for Health Humanities and Ethics at the University of Virginia School of Medicine. Welcome to the Medical Center Hour. This weekly forum on medicine and society, which has always welcomed the public, in this COVID era now welcomes everyone from everywhere via Zoom. Thanks so much for joining us. Our fall semester schedule is posted on the website for our Center for Health Humanities and Ethics. Please do join us for Medical Center Hour each Wednesday. You might make us your weekly virtual lunch date. Our Zoom session opens and ends with a rotation of slides about today's program. These slides provide a short reference list and a link to our center's website, where you'll find the presenters' bios, information for clinicians about continuing education credit, and a link to previous programs' video recordings on YouTube. Today's program is being recorded, will be posted to YouTube. Lively exchange between our audience and presenters is a Medical Center Hour hallmark. But on Zoom, we ask you to enter your questions and comments into the Q&A function. We'll monitor the questions throughout the hour and draw from them for our speakers' consideration in the closing minutes of the program. As ever, we value your views, and because we do, I urge you to use the Q&A function. Today's program, The Science and Ethics of Developing and Allocating COVID-19 Vaccines, is the second of 3 programs in our fall semester mini-series, Pandemic Perspectives 2020. Hopes for confronting the COVID-19 pandemic and restoring socioeconomic activities to something resembling normal rest in part on the prospect of a vaccine for SARS-CoV-2. Vaccine development and testing are now underway, proceeding at unprecedented, some say warp speed. If one or more vaccines now being tested prove safe and effective soon, even before the end of this year, supply will still be too scarce to vaccinate everyone in the US immediately. So vaccine must be rationed. This Medical Center Hour explores the scientific process, promise, and challenges of fast-track vaccine development and ethical deliberations about equitable vaccine allocation. Our presenters are 2 distinguished members of the University of Virginia faculty. Dr. William Petri, Wade Hampton Frost Professor of Medicine and Vice Chair for Research in the Department of Medicine, is an expert on immune mechanisms of defense against infections, including COVID, and he's involved with COVID vaccine teams here at UVA. He's also involved in COVID care and actually is speaking to us today from UVA's COVID clinic. James Childress is University Professor Emeritus and the Hollingsworth Professor of Ethics Emeritus, an expert on biomedical and public health ethics. He's a member of a National Academy of Medicine committee that, having also worked at unprecedented speed, just last Friday, October 2nd, issued its report, Framework for Equitable Allocation of COVID-19 Vaccine. In tag team fashion, these 2 speakers will discuss COVID-19 vaccine development and the ethics of its allocation. Professor Childress will pay particular attention to the National Academies report. We're very grateful for their contributions toward helping to turn the COVID tide, even as this global pandemic persists, with more than 1 million dead worldwide and 211,000 in the United States. Dr. Petri, welcome.
Oh, Marcia, thank you very, very much. And it's a really honor to speak in the same session with Professor Childress. And you guys won't know this, but probably about 10 years ago, Jim was instrumental in helping us work out ethical issues around following cohorts of children in an urban slum in Bangladesh, how to do that in an ethical manner. And as Marcia is saying, I am in COVID clinic right now, and it's very relevant to what we're talking about today. I'm leading the local UVA part of a phase 3 clinical trial to study antibodies against the virus, and can we actually prevent household transmission of COVID-19. And so our subject today is a UVA undergraduate student whose roommate was diagnosed with COVID-19 this week. And so the subject will receive either the placebo or the monoclonal antibodies against the COVID-19 spike glycoprotein. So with a randomized double-blind prospective study will be part of a nationwide effort to assess whether COVID-19 can actually be prevented. And these are the same antibodies that President Trump received when he was first diagnosed. And in his case, the timing was quite ideal because the initial phase 3 results of the use of these antibodies to treat as opposed to prevent COVID-19 were released, demonstrating that in fact that receipt of the antibodies decreased the duration of symptoms from 13 days to 8 days, and also decreased the amount of virus in the nasopharynx by about 50%. So we know that these antibodies work to treat COVID-19 from these very early results from a phase 3 clinical trial from Regeneron. And now what we're seeing is can we actually use them to prevent, in this case, in one of our UVA students. Well, this is like very apropos to the discussion of vaccines for a couple reasons. First, antibody treatments are probably going to be a stopgap until the vaccine is available. And so the US government is going ahead and actually producing several 100,000 doses of these vaccines right now in order to be ready should, with the phase 3 results coming out for emergency use authorization. So they're a stopgap or filling before the vaccine is widely available, which we'll talk about. They also are a proof of concept or give us an understanding that the way that the vaccines are being designed is correct. Because the vaccines, and you've heard that there are 4 or 5 vaccines that are in clinical trials in the US. There's upwards of a dozen that are in phase 3 clinical trials around the world. The goal of all of these different approaches to vaccination is to make an antibody response against the spike glycoprotein of the new coronavirus. And what has been shown with these Regeneron monoclonal antibodies against the spike glycoprotein are that, in fact, when administered during the course of disease, they provide protection. And so this is the very thing that the vaccines are designed to do. So it's sort of unusual early in vaccine design to actually know that you're taking the exactly correct approach, but that is the situation here. So what I thought I'd tell you briefly about after that introduction is a little bit about the illness, and then the vaccines and the approaches to have those vaccines evaluated. And everyone, of course, understands that this is a coronavirus that jumped over from a bat, maybe via a pangolin, into people in China in the late fall, early December of last year. What you may not know is that it's an RNA virus. And that's important because in general, RNA viruses mutate quite rapidly. That's why we haven't been able to make a vaccine yet for HIV or for hepatitis C virus, the Nobel Prize yesterday, but we still don't have a vaccine because those RNA viruses mutate extraordinarily rapidly. Well, the new coronavirus that causes COVID-19, it's such a long RNA virus, it's 3 times bigger than HIV or hepatitis C, that it can't afford the high mutation rates that these smaller RNA viruses have, because the chances are you'd end up with a dead virus with a high mutation rate. And so it actually has evolved to have a proofreader, and it's not that different from like typing on your computer and having spell check on Microsoft Word. The proofreader corrects errors that the RNA polymerase makes. And that is like really, really good news for all of us, because what that means is this is not a rapidly mutating virus. This is a a virus that is a stable target for a vaccine. And that's one of the very, very positive things about the virus as it applies to producing a vaccine. The second thing sticking out from the ball, like those spikes, and that spike glycoprotein is the Achilles heel of the virus, because the virus needs to use that spike glycoprotein to attach to human cells and enter the cell to start an infection. And we know from cryo-electron microscopy the exact portion of the spike glycoprotein that attaches to the human cell. That's called the receptor binding domain. And again, that has been very antigenically stable. I think there's only been a single amino acid substitution that's been noted in that receptor binding domain. And again, like all of these vaccines are designed to develop antibody responses against that spike glycoprotein. So the basic concept of vaccines is that they're going to prevent infection with a new coronavirus, because the virus will never be able to get into a human cell, because the antibodies will neutralize the attachment protein of the virus. And that's what we're doing in this study at COVID-19 clinic at UVA, is actually testing the administration of those antibodies against the spike glycoprotein to prevent the illness. It's just then a word about the illness that we're trying to prevent. It is fascinating as an infectious disease specialist to see a new infectious disease, just as terrible as that is. It is also, of tremendous interest, and the rate at which things are being understood is really extraordinary. What we sort of have figured out right now is that very early on in the infection, that inflammation is a good thing. And so having an active immune system is protective early on in the first few days of the illness. And in 80% of people, that early activation of the immune system is curative, and that's the end of the problem. For reasons that we don't totally understand, in about 1 out of 5 people, that inflammation, though, does not clear the viral infection early on, and one actually is left with continued inflammation, which is now damaging to the host. And one of the things that we have discovered at UVA with Allie Donlan, who's a graduate student in my lab, is that the kind of inflammation that is bad is quite similar to what you see with asthma. And so it's what we call a type 2 allergic immune response. It's characterized by a couple cytokines or immune signaling molecules called IL-4 and IL-13 that are causing inflammation in the lungs and actually causing the pneumonia and the hypoxia that you hear about. And so in a mouse model of COVID-19 that we do in the BSL-3 labs here, we've actually been able to show that we can intervene in the illness after the infection's happened by neutralizing these allergic cytokines. And so that's exciting to me, because that offers us new therapeutic avenues for patients that are ill enough to come into the hospital. But I'm making the distinction between early inflammation being good and late inflammation being bad, because this, of course, came up with the president's illness. As all of you know, the president received the Regeneron monoclonal antibodies that we're studying here in COVID clinic. He also received remdesivir, which is an antiviral that Patrick Jackson led the local phase 3 study of at UVA. And then the third drug that he's receiving is a prednisone-like drug called dexamethasone. And dexamethasone inhibits inflammation. And dexamethasone saves lives for patients with severe illness. So after that early inflammation is over, and if the 1 out of 5 patients that gets late inflammation and hypoxia, dexamethasone has been shown to save lives, reduce mortality up to 1/3. And so that was like in the news, just because that sort of told us that the president's illness was more severe than we had originally thought. so that's the with the illness, and then going with the vaccines. So where we're at right now with the vaccines, again, we've had like phase 1 and phase 2 clinical trials, and these have shown that the vaccines are safe, and the side effects have been the kind of things that you expect after vaccination. So local soreness, tenderness, warmth at the site of vaccination, and then also sometimes systemic symptoms like a fever or muscle aches that's usually lasts about 24 hours or so. And so there's good evidence from phase 1, phase 2, which are small studies. Those are hundreds of patients, not tens of thousands, that the vaccines are safe. And so what we have going forward right now then is phase 3 studies. And there's 2 that are sort of up ahead that are probably going to be most relevant to the deliberations of the panel that Jim was on for the National Academy. And those are made by Moderna and by Pfizer. And these are both this novel approach of making a vaccine where you put the RNA inside of a lipid droplet or a liposome. And then that actually instructs the human body to make the spike-like a protein for an immune response. And so both of those studies, both the Moderna, which is supported by the federal government, and the Pfizer, which is being just run by Pfizer without federal support, both of those started July 27th. And so you can kind of like do the math that they started enrolling probably 30 to 40,000 patients July 27th. It's a 2-dose vaccine. And so, the very first patients will have finished vaccination August 27th. And then the basic idea is that just to follow the patients for natural infection. And the FDA has set as a goal that the people who receive placebo should have twice the rate of COVID-19 infection as those who receive the vaccine. And so that's the goal. And that's that data is being accumulated right now. And so, we'll know, presumably, I would think like within weeks or to a month or so, which of these vaccines is effective. And where we're at right now, again, if you do the math, and then so the first subject would be 2 months out from completing the second vaccination, October 27th, so like a couple of weeks from now. And then what is an additional FDA guidance that we received just yesterday is that they're going to want to have subjects followed for a minimum of 2 months after the completion of the vaccine before they'll approve it under the emergency use authorization. So this will probably push approval of a vaccine back a bit because now there's this requirement for 2 months after the last shot of the vaccine. And both the Moderna and Pfizer are 2-shot vaccines. And then what will happen, just to close with emergency use authorization, is that the FDA will still require the companies to continue to follow the subjects of the vaccine study, just as they would do under a normal authorization period. And so it kind of gets into like the subjects will continue to be followed with the idea to look long-term for safety for the vaccine. So exciting time. I'll kind of turn it back to you, Marcia, after that sort of overview about what's going on with vaccines. And thank you.
Thanks, and we will turn now to Jim Childress to take us into the ethics of thinking about once we have vaccines and the planning in advance for how we will be allocating a limited supply of vaccine. Jim.
Okay, thank you. And thanks so much to Dr. Petri for sharing this program today with us in the midst of his own clinic work, which is so important. Thank you very much, Bill. So let's see, make sure that I want to go back to slide 1.
Just push your...
my cursor won't work. So is Richard,
I'm here. Can you use the buttons at the bottom left of your screen?
oh, okay, those are the ones I should use yet. Okay, great, thank you.
Good.
All right. So given what the picture that Dr. Petri described, it's clear that once we get vaccines available, one or more, there will still be a period when the vaccines are in scarce supply. And so one of the big questions is, how should they be allocated during that period? What would be an equitable, fair, just way to allocate these scarce vaccines, given the fact that we're facing this pandemic, need to bring it under control, need to distribute the resources in a way that can be most helpful, but also in a fair, equitable, and just way. So the National Academies of Sciences, Engineering, and Medicine conducted a consensus study report under the sponsorship of the Centers for Disease Control and the National Institutes of Health with an ad hoc committee to develop a framework for equitable allocation of COVID-19 vaccine. The National Academies are independent source of advice to the government, effort to offer objective advice. And they go back in some form to the establishment in 1863 by President Lincoln of the National Academies of Science. This particular committee of 18 people from several different specialties, backgrounds, you can see here is the membership, started meeting in July, and in this fast-track study, managed to produce a report that was released to the public last Friday, as Marcia mentioned. These consensus study committees are designed to build on expert opinion, but one of the things that made this particular one different is that we really did attend in a way that a lot of other committees do outside the National Academies to getting public input. So we started by reviewing the literature. We had 8 virtual committee meetings and numerous work group meetings. And we held 3 public meetings. One was a public listening session of about 5 hours with 50 plus presenters offering their viewpoints or viewpoints of the groups they were representing. And in addition, we had over 1,400 written comments. And responsibility of a committee like this, consensus study committee, is to incorporate criticism and suggestions offered by the peer reviewers. And so it goes through that process, but in this case also from the public. And so this was a very important part of what we were trying to do. So what did we work on? Well, our effort was to develop a framework of equitable, fair, just allocation. And at the first meeting, at which we got our charge from the National Institutes of Health and the Centers for Disease Control, Dr. Francis Collins suggested that we pay attention to foundational principles that could be used in a variety of settings. And so we did that, and I'll talk about them in a moment. But then in developing this framework, we also developed a primary goal, and then we developed risk-based criteria for allocation, and finally ended up with 4 allocation phases. So that's the overall framework. Now, let me say something about the parts. So in terms of ethical principles, we identified 3 that are very important for thinking about how to allocate scarce vaccine and other resources in response to the pandemic. The first, in thinking about this specifically for COVID vaccines, focus on maximum benefit, which includes the obligation to do 2 things. One is to protect and promote the public's health, but also its socioeconomic well-being, and thinking about both of these in the short term and the long term. So maximum benefit encompasses a lot. Another principle that guided our work is that every person should be treated as an equal. That is, say, considered as and treated as having equal dignity, worth, and value. And then a third principle that is very, very important in the context of this particular pandemic. And I would just might add parenthetically that the Yale historian of pandemics, Frank Snowden, has indicated that each pandemic has its distinctive personality. And that has to do with modes of transmission, who is affected, their ages, the severity of responses, and so forth. And in this particular pandemic, one of the major concerns has been the disproportionate burden borne by certain communities, particularly communities of color. And so a third principle that we emphasized was mitigation of health inequities, including the obligation to address explicitly the higher burden of COVID-19 experienced by populations most heavily affected in view of their exposure and their compounding health inequities. And just should note as an example that African Americans compared to white non-Hispanics have a 2.6 times higher rate of infection, a 4.7 times higher rate of hospitalization, and a 2.1 times higher rate of death. So this principle directs us to attend to those populations most heavily burdened by this pandemic. So these three fundamental principles direct us toward particular ways of allocating resources. But we also have three procedural principles. And fairness requires an engagement with the public, especially those most affected by the pandemic, as well as impartial decision-making about and even-handed application of the criteria and the priority categories that we call phases, and I'll talk more about them later. But another procedural principle is the obligation to communicate with the public openly, clearly, accurately, straightforwardly, what we call transparency, about the framework as it's being developed and deployed and as it's being modified, because there will be changes in relation to the vaccines as they're rolled out, but also any changes in the pandemic and its effects. But in doing all this, we have to have science and evidence. And the allocation framework, its goal, its criteria, its phases, all those need to be based on and the best available and constantly updated scientific information and data. So you bring the principles to bear, but only in relation to the best evidence we have about the pandemic and about the vaccine and so forth. Now, a few words of comparison with other frameworks, because there are many frameworks being presented for equitable allocation of vaccines, but also therapeutics, ventilators, and so forth in relation to patients with COVID-19. This slide focused on four. These were not only groups that were trying to develop a scholarly framework, but also groups that were set up in order to develop a framework that could be put into practice. And so our committee's foundational principles are given here on the left. I'm sorry. Our committee's foundational principles are given on the left. And I've just gone through those, so I need not repeat them. And as you move across from the left to the right, you'll see a Johns Hopkins interim framework, a WHO framework from its strategic advisory group of experts, and the advisory committee on immunization practices and its work group looking at the ethics equity framework for allocation of vaccine. These vary in many terms, but they also represent clusters of ethical concerns. And even when there's different language, there is substantial overlap. There are some differences, of course, but it's also important that there is overlap. One wag once said that originality in ethics is almost always a sign of error. It is reassuring to see the overlap among these frameworks, even again when they're not identical. So with the framework that this committee was working with, we turned to a goal. What's a primary goal? And we stated in terms of reducing severe morbidity and mortality and negative social impact due to the transmission of SARS-CoV-2. This goal focuses on that reduction as the major problems faced by many of those who are afflicted with the infection. And it focuses on the negative social impact that often occurs, especially when people end up unable to discharge essential or important functions in the society, all as a result of the transmission. So this is getting at how do you respond to that distinctive personality of this pandemic. Now, in moving from the foundational principles and goal to the criteria, we ended up focusing on risk-based criteria. In thinking about the priority groups, we thought in terms of what's the risk of acquiring infection? What's the risk of severe morbidity and mortality? What's the risk of a negative social impact for groups acquiring the infection? And what is the risk that those groups have of transmitting the infection to others? Now, let me just say a few more words about that in relation to our efforts to mitigate the effects of health inequities, because these play a role there too. The risk of acquiring infection is affected by a variety of social determinants of health that have to do in part with overcrowding, with work conditions where people cannot adequately protect themselves. The second risk, the risk of severe morbidity and mortality, often reflects the presence of underlying conditions and comorbidities. Again, often an indication of the health inequities that we noted earlier. And then the risk of negative social impact, I've already mentioned in terms of the loss to the society, if people are unable to continue in their roles, and then the risk of transmitting infection to others. Now we move to the most complicated slide, where these risk-based criteria and the goal and the principles are thought about in relation to the phases of allocation. First, a word about the phases. Any of you who have looked at discussions of party groups will be quite familiar with the language of tiers. Think about the first tier, the second tier. This committee decided that to move away from the language of tiers and to talk about phases instead. The language of tiers suggests a kind of hierarchical structure. Some people are above and some people are below others in the allocation scheme. They tend to be more static in nature. We were thinking in terms of phases, that the goal is to move as quickly as possible to making a vaccine available to everyone in order to bring this pandemic under control and to save lives and reduce severe mortality, to bring the economy and socioeconomic activity broadly back into full flourishing. All those things are important. But given the anticipated shortage of the vaccine for some time, we'll need to phase this in. And so we developed phases for bringing the vaccine into fruition in different groups. And we start with phase one, a jumpstart phase that focuses on high-risk workers and first responders. And that's a jumpstart when just is available. If there's enough available for all of phase one, then we bring in all people of all ages with comorbid and underlying conditions that put them at significantly higher risk, and older adults living in congregate or overcrowded settings. That would be phase 1. And that would represent, if we have 1A and 1B together, that would represent about 15% of the population. And then in phase 2, a much larger phase, which would represent about 30 to 35% of the population, we bring in other groups, including the teachers in school, K-12, and teachers and school staff and workers. And then notice we've moved from the workers in phase 1A to critical workers in high-risk settings, essential to the function of society, but at substantially higher risk of exposure. And then people of all ages with comorbid conditions that put them at moderately higher risk, whereas in phase 1B, we were talking about significantly higher risk. And then the next two phases within this phase 2, the next two groups focus on those in homeless shelters and group homes and so forth that put individuals at risk, and often those are people with disabilities of various kinds, but also the staff who work in those settings. And then people in prisons, jails, detention centers, and similar facilities, and the staff. And then all older adults not included in phase 1. They would have been in that group, but here include the other older adults. And then phase 3, which would represent about 40 to 45% of the population, young adults and children, all of whom end up being susceptible to the novel coronavirus, but tend to have less severe health outcomes. Many do develop major problems, but as groups tend to have less severe health problems. And then also workers that are important. They're in functions and industries that are important for the function of society, but at increased risk, in contrast to the other, where we're talking about moderate risk, and then before that, significantly higher risk. And then phase 4, which would represent about 5 to 15% of the population, everyone in the US who did not get the vaccine earlier. Now, when groups testified before us, often they were raising claims about, our particular group would represent a population that needs priority. Well, one of the most interesting ones, not before our group, but before the Centers for Disease Control group, actually was from the professional organization of Real Bearded Santas, who were making the argument that Santa Clauses, our professional Santa Clauses and other seasonal workers need priority over the holiday season because of the exposure they will have to people. That's just an example of the way in which you can see how, even if you develop some categories, how do you decide who fits in to those categories? Another important consideration has to do, down at the bottom of this slide, with equity as a cross-cutting consideration. We're suggesting that in each population group, vaccine access should be prioritized for geographical areas as access and delivery and reaching out to geographical areas identified through the CDC's Social Vulnerability Index or some other more specific index, one developed specifically for COVID-19. So this is functions across. In addition, we suggest that it may be appropriate to reserve 10% of the vaccine to go into areas where these outbreaks are most severe because of these conditions. As I bring this to a close, let me consider a few other factors, including factors related to implementation, because this is clearly going to involve a lot more than simply setting out priority groups. You're going to have to develop ways to administer and implement the program. You're going to need risk communication, and also, as I've emphasized several times, community engagement. In part because one of the key factors here will be developing and achieving public acceptance of the vaccine. We have anti-vaxxers generally, but then we also have people who are particularly concerned about the development of these particular vaccines, in part because of the language of Operation Warp Speed. Some have expressed their concerns about this being developed too rapidly. They worry that indeed corners might be cut. Now, the anticipation is that the FDA will be very rigorous on this before approving emergency authorization. Will receive rigorous scientific analysis and input, and that we will have vaccines that are, we hope, safe and effective. And at that point, then we really need to be working on the making sure that there is public acceptance, or otherwise, if there's not trust, then this public health program will fall far short of what it needs to be. Our recommendations include, and I'll come back to that last one about a global perspective. Our recommendations recommend adopting this particular framework using existing structures. But then the third bullet, providing the vaccine with no out-of-pocket cost for those being vaccinated. That includes no cost for administration. These vaccines are supposed to be provided free, but also no cost for administering them. Recommending funding COVID vaccine risk communication and community engagement program, a vaccine promotion campaign, and once safe and effective, and building the evidence base for strategies to promote and to gain acceptance. Now, the last one I'll focus on for a moment, and that has to do with equitable allocation of COVID-19 vaccine globally. Our task was to really look at vaccine allocation within the US. And yet we felt we could not deal with this without paying attention to the equitable allocation of vaccine globally. And so we have a recommendation that the US government commit to a leadership role in the equitable allocation of COVID-19 vaccine globally, including opting into the COVAX facility, the Global Alliance for Vaccines and Immunization, deploying a proportion, for example, 10% of the US vaccine supply for use globally, and also re-engaging with the World Health Organization and member states to optimize the fair and equitable allocation of COVID-19 vaccines within and between nations, regardless of their income level. So we felt this was important both on ethical grounds and on grounds of protecting the US. So in this interdependent society, both the ethical and the protective reasons are significant. So there's a free PDF of the report available at the following link. And I will stop there.
Great, thank you, Jim. We have a generous amount of time for your questions and comments. Please write them into the Q&A function on Zoom. We've had a few questions for starters, and they tend to be directed to Jim, both for purposes of clarification and then extension of some of what you were saying. And those of you who might be able to see Dr. Petri's computer station will notice that he's not there at the moment. He's actually finishing up with a patient. So he will be rejoining us momentarily. But I think we'll start questions with Jim and begin first with one of the easiest clarifications. Someone wanted to know the category older persons in the report. Who's that? Is 65 plus?
We tend to think of 65 plus. That's a kind of guidance we're working with. There are then people at higher risk, 80 plus, et cetera, but we were using that cutoff for the most part in the report.
Good, thank you. And another clarification question. Why does the place of residence of persons with disabilities play such a central role? And this questioner mentions that some actually may be living on the streets or with family, and therefore maybe more or less at risk, or maybe not in so much contact out in the society at all. But can you elaborate a bit on the thinking about persons with disabilities?
So think about that in two different ways. One is that some of these disabilities are reflected in comorbid and underlying conditions that can increase the risk of individuals. So it can be a risk-based factor. But then in phase 2, we focus on people in homeless shelters or group homes for individuals with disabilities, and then a range of those disabilities and the staff who work in those settings. So there is often considerable exposure in those settings and in the staff who work with those persons. So this is in part the interest that we have in recognizing that living arrangements often do complicate the exposure to risk, the risk of exposure to the novel coronavirus. And so in phase 1, we had mentioned older adults living in congregate or overcrowded settings. And so here we're still staying with the situations where individuals are living together, or if you're thinking about the homeless, in homeless shelters where they're brought together at least for part of the time, and the risk involved for the individuals there, but also for the staff involved in providing the care. And again, the kind of group focus we have had includes people in prisons, jails, et cetera, as well.
Okay, good. Another question, discuss how your committee thought about the process, given that there are a variety of vaccines, and this may be a question, welcome back, Bill, this may be a question that both of you would want to answer. So in interest of recognition, as Bill had mentioned in his remarks, that there are many vaccines currently in development and testing. And Bill, I think you also alluded to the fact that there are some that require 1 dose and others that require 2 doses, anywhere from 2 weeks to 2 weeks to 4 weeks apart. So how are these plans for allocation and distribution of the vaccine taking account of these different versions of vaccines and the difference in how many doses are required for vaccinating these various populations in Jim's committees?
Well, I'd start, and then Bill, welcome back, and get you involved. So obviously, this is the uncertainties I mentioned about the vaccines certainly play a role and will play a role in how these are rolled out for allocation and distribution, and especially for the sort of distribution part, because you're not, in addition to the points you mentioned, Marcia, some of these require freezing at a very, very low level. So that's going to limit the number of facilities that can actually use them. So that's, all those will play a role in. That's why we indicate that our framework will have to be adapted to the best available evidence at the time, given whichever vaccines become available and have been established to be safe and effective. So let me stop there and turn it to Bill. He's muted.
You're still muted.
Sorry, it said if I hit the space bar, that would work. Apparently not. So thanks. Marcia, I would say like that the one good thing is that we're already doing this for the influenza vaccine. And so you actually have your choice of about like 10 different flu vaccines, and some are optimized for the elderly, some for children, some for them under age 50. So I think that'll help with it seems like otherwise an impossibly complicated task. And as Jim is saying, like that some of them require that they be stored at temperatures as low as -70 or -80. And so that's some vaccines will be limited for that reason. And of course, like we have, like you were mentioning, Marcia, the need to boost most of the vaccine. I think the Janssen vaccine is the only one that's a single dose that is in clinical trials right now.
Okay. Here's a question, and maybe for both of you, it's highly relevant since this program is coming to people from a university. How important is it going to be for college students to be vaccinated?
Well, I think it's like really important for two different reasons. First is they're at low risk, but not no risk. And so number two is, of course, is that they are potential vectors of the infection to their parents, to their grandparents. So two good reasons. That's the same approach we take with influenza. We recommend that every person who is 1 year of age and older be vaccinated against flu. Part of the advantage of that is that the elderly are the ones that need the vaccine the most and in general respond the worst. And so sometimes it's easier to protect the grandparent by vaccinating the grandchild. And so I think it's a similar approach for COVID-19.
Mm-hmm.
And let me just follow up on that. I agree with Bill completely. We put the young adults and children, so that would encompass presumably the college-age kids. We put them in the third phase after the first two. One can make an argument if we were another. So part of the debate here is, do you focus on reducing transmission, or do you focus on, first of all, on reducing severe morbidity and mortality? And it was a sense of the committee that actually in those very early phases, you get the most for money for your buck for your money, whatever the word would be, expression would be here, if you concentrate on reducing severe morbidity and mortality. We wouldn't have enough vaccine to have a major impact on the transmission at that point. And so we put it in the third phase, but recognizing that, yes, young adults and children, again, including college-age students, would be important, especially as vectors, but also because some of them do become severely ill and die.
So another question that has to do with not so much with the supply of vaccine itself, but also the related material for delivering vaccines, everything from the vials and syringes and things like this. We've seen some other sort of supply line shortages, quite critical at other points in this pandemic. And given that that COVID vaccines will be rolling out along with a major influenza vaccination program, what are your thoughts about ways that we can anticipate and actually ensure that there's an ample supply in order to get this vaccine actually into people?
Well, Marcia, I can jump in, and I'm like Thomas Jefferson I'm not a big fan of the federal government, but I think they've done like an amazing job, and not just with Operation Warp Speed as far as like funding multiple independent approaches to vaccine production, but they are already funding the major distributor of vaccines. So there is like a really wonderful sort of trying to stay ahead of the curve with this. I think that'll help us with distribution.
Okay.
And I think that's right. One of the concerns that has emerged in some communities is the report that of the involvement of the military in distributing vaccines. If this is simply a logistical role, that shouldn't be a problem. If the role is beyond that, that for some communities would raise the issues of distrust to a higher level and would make it more difficult, perhaps, to get vaccine acceptance.
Well, actually, we did. Go ahead, Bill.
I was just going to say, Jim, yeah, that is my understanding. I guess there's a general who is in charge of distribution, but I think that's because of like his logistics understanding. It always amazes me. You ever do like a family camping trip and how many preparations you have to do to have like 3 people in a tent. You can't imagine how the U.S. Army does that with 100,000. They're probably like the best people to understand the logistics.
Mm-hmm. And a related comment to that, not only about sort of the inanimate supplies and things, but also an adequate pool of providers to inoculate individuals. I think we've seen in some of the testing programs a community call for people who could be trained to administer COVID tests at some of the drive-through places. So really assuring us of an ample supply. The military may be one answer, but yes, we will need more people. A question maybe more for Bill. Once the vaccines are deployed and after the testing is done, is there some sort of central clearinghouse where reports of side effects or lack of vaccine efficacy, where do those get reported and assessed? And what's that process like? What kind of feedback loop is there, especially with multiple vaccines?
Mm-hmm. Well, the FDA, if they approve a vaccine at the end of the year, is expected they will, it'll be under their emergency use authorization, which is a very special pathway. That's how all the diagnostic tests, for example, for COVID-19 have been approved, is under EUA or emergency use authorization. The FDA is going to require the companies that get EUA approval to continue to follow the subjects of the phase 3 studies out for a full year, which is much more the standard approach. The FDA also has a post-approval marketing surveillance program to look for the rare side effects, because like, with 40,000 people, we're going to have a pretty good idea of adverse events, but that's not going to detect the 1 out of a million cases of a rare event, and that's all going to be required just following for post-marketing.
Okay, yeah. We've come close to the end of our hour, and one of our questions actually is a question that I'm going to turn back to everyone watching, because it's a question that at this point I think we don't really have an answer to, but it may be the question, the burning question for all of us, and that is, do we think the results of the coming election will affect how the vaccines are deployed and delivered, how the National Academies or other frameworks will be utilized as we move into a time when there is or there are vaccines against COVID. So we'll just leave that question sort of in the air right now. And I would like to thank Bill Petri and Jim Childress for a very rich hour of conversation right at the edge of the work that's being done to tame this novel coronavirus and its effects on our globe. I ask you to come back next week. We're going to take a different look at the globe and actually at the Commonwealth in a program called Climate Change in the Commonwealth Health Implications. And we'll have as our principal speaker the chief scientist from the Science Museum of Virginia, Jeremy Hoffman, also a clinician from Virginia Clinicians for Climate Action, and a UVA medical student who's working with a medical student interest group to promote consideration of climate and health in the medical school curriculum. Again, thank you all so much, and we will see you next week.